Yeah, so the next speaker will be Dr. ATHEEK. So he'll be going through the process of selecting the perfect patient to undergo a small incision lenticle extraction.
Good morning, everyone. Yes. The workup of SMILE is no different from any other refractive surgery. It's more or less the same. I think anybody who reads topography and people who do who do refractive practice, most of us will get this. It will be sent via WhatsApp. You get a picture of the topo and AR, and we are asked whether can we do refractive surgery for this patient. Well, topography and AR, with this you cannot take a decision whether any refractive surgery can be done. So that is the take home I want to give. So this is something very important. History and evaluation are equal, at times more important than just looking at these two results. Though it is boring, you need chair time, you need to talk to the patient. Age is absolutely important. A patient with a -5, -1 at 25 years, how you will correct the patient is totally different when the same patient is 36 or 37 plus. Occupation of the patient, there are certain occupations where flap-based procedures are not allowed. So examination and history from the patient as to why they want to do the procedure also needs to be taken before giving options to the patient. This is how we get most of our patients. They want our procedure to be absolutely successful, absolutely safe, totally painless, lasts forever, never anything is got back. They want it right now, either free or via insurance. These sort of patients is what we get usually when it comes to refractive practice. What we have to understand is no procedure is 100% safe. Even if all parameters are within the green zone, all of us would have encountered at least once or twice a perfectly normal patient with a great residual bed going in for ectasia. So saying certain things like 100% safe, you will be absolutely free of glasses is not the way forward when you're looking at a good refractive practice in the long term. So in these sort of patients who question more, you need to give them more chair time, understand what they're expecting. Patients in gray zone, better to use simple vocabulary, ensure that they understand, give them realistic expectations about the procedure, and then go ahead. This is something that another issue. This was a patient was sent asking whether refractive can be done, and the question was refractive surgery done? Yes. Does the patient have a flap? No. So again, these sort of things we cannot take a call just looking at the topography. Examination is very, very important. And refractive history, when the power started worsening at younger age, more in favor of KC, above 30, pellucid margin degenerations can be considered. So stability for at least 6 to 12 months is very important when we are considering refractive procedures. Soft lenses preferable to be off at least for a week's time. Otherwise, it can cause changes in corneal thickness, irregular astigmatism, and also false positive or false negative values. Dry eye is something that's very important. Again, it gives absolutely haywire, irregular astigmatisms. It gives us wrong K readings. So dry eye is something that needs to be evaluated. Hyperlacrimation at times gives an image of an ectatic disorder. This is a patient who was having lacrimation, and you can see the K is around 54.2, and you can see that the tear meniscus is quite high. So these sort of patients, you need to treat the MGD or the dry eye. If possible, give a small window period for this to settle down, call the patient back, redo the topography, and then take up the patient for the procedure. Rubbing is something that's very important. Ask for history of allergy. So in these sort of patients, SMILE definitely has an add-on because there is no flap, and flap-based complications are negated. General history from the patient. Diabetes, we need to be very keen and properly ask the patient. Most of our patients who have diabetes, you ask them, do you have diabetes? The answer will be no. But they will say, I'm taking medicines, it's under control. So according to the patient, they are not diabetic. But this again needs to be properly taken into consideration because diabetes can cause a myopic shift. So any patient with high blood sugar levels, we need to wait for 4 to 6 weeks for it to settle down, ensure that the refraction stabilizes, and then taken up. Same applies for hypertension too. We need to be cautious. Patients with allergy, Patients on antihistamines having dry eye, again, we have to be careful with the workup done, because we will be getting falsely estimated topo and we may be giving more rejection. So these sort of patients, we need to be cautious. Patient with collagen vascular disease, always safer to avoid these patients. A negative workup of Sjogren's is very important. They can be considered provided it's just a mild disease and TBUT is normal, we can go ahead. Again, SMILE is preferred over LASIK and flap-based procedures. Pregnancy and nursing, very simple answer, better to avoid any procedure during pregnancy because the corneal biomechanics is totally changed. The rigidity of the cornea is lost. The cornea is more flexible courtesy estrogen. Same thing applies for patients on hormone replacement therapies. Anybody on estrogen or progesterone, we need to be very cautious. Mainly estrogen affects the corneal biomechanics. Antihistamine just said that it causes dry eye, and patients on antidepressants and anxiolytic, it is very difficult to make the patient lie down, dock and do the procedure because they are not that very cooperative. For refractive surgery, you need good cooperation from the patient side to get good results. Steroids, again, a lot of changes happen, so patients on steroids is better to be very cautious. Family history of KC, again, very important, mainly at least first degree relatives. You need to take that extra time out of those patients, be very cautious, careful, do a proper evaluation, and then take up the patient for surgery. Refraction, something that's extremely important. A proper cycloplegic refraction needs to be done. JCC should be used to confirm the magnitude and the vector of astigmatism. Last time I heard Adit and Arul sir saying that they no longer check the patient up to 6.6. They are dropped still further to analyze what the patient is capable of reading. They even drop down to 6.5 and 6.4. That is absolute BCVA is calculated. 6.6 is not the ultimate what we can try. So that definitely needs to be considered. Ocular surface analysis, usually only dry eye is considered as an ocular surface disease. Definitely it is not. We need to consider the ACRS OST algorithm. Look for the lids, do a BUT. If you have access, NIBUT definitely has advantage over it. Evert and see all patients to see for any allergies or bullae. Do a meibomian gland expression, press the gland and see whether you're getting clear fluid. At times, we'll be able to see pus-like fluid coming out. Again, they affect topography values, and the corneal surface also drying will be a little difficult. Those lipid sort of things comes immediately when we put the speculum. So treating it and then taking up the patient for surgery is something that's very important. Patient with eccentric pupil, better to avoid refractive surgery. Glaucoma is a gray area, again, better to avoid refractive in these patients. Fundus examination should be normal. So basically, good stable refraction at least for 1 year is very important. A few slides on topography. So to begin with, the quality indices, it has to be normal. Check the quality specification, ensure it is okay. Sometimes when we have the yellow zone or if it is red, it indicates that either the patient has moved or a small tilt has happened. So before we read or interpret the scan, ensure that the quality specification is fine and then go ahead with estimating the values. At times we will be able to see multiple dots on the topography. This indicates that the lid was not open and the machine has extrapolated the values. So these sort of cases always encourage the patient to open the eye widely, repeat the scan and then go ahead with interpretation. So checking quality specification is as important as knowing how to read the corneal topography. K reading, first thing you want to check is if it is less than 46, it's perfectly safe. If it is anything above 46, you have to see it with little bit caution. More than 48 is definitely a red flag. Inferior asymmetry is something what we are looking at the 4 mm zone, difference between the superior and inferior areas. If it is more than 1.5, it is considered as a red flag. Superior steepening, though not very common, at times we will be able to see it. At about 2 to 2.5 is considered a red flag. Again, sometimes we get false superior steepening sort of picture when there is a tear accumulation just below the lid margin. So that needs to be checked and we have to ensure that that is not there. That is where clinical examination is important. Just looking at topography and giving results is a little, that's not the way forward to analyze. Skewing, again, it indicates or is commonly seen with ectatic corneal disorders. So skewing of more than 21 or 21 and above is considered a red flag. Skewing less than 20 degrees can be considered okay, provided all other parameters are also fine. Abnormal shapes, when we see the elevation maps, either island or tongue shape extensions are red flag signs. Along with this, other parameters also needs to be checked. When we look at the anterior elevation, some studies say cutoff of about 12 is okay. Some people go up to 15 to 20. So to be very safe, anterior elevation less than 12 is absolutely safe. Posterior elevation less than 17 is safe. And more importantly, when we have a big difference between the anterior and the posterior elevation, we have to view it with caution. Difference of less than 7 to 10 is okay. When it is more than 10, we have to view it with caution, because usually ectasia starts in the posterior surface and then comes towards the anterior surface. Pachymetry thinness point less than 470 is normally considered not okay. So about more than 500 is definitely safer. Then the coordinates of thinnest location, again less than 0.5 is safer. More than 1 is a red flags line. Then the difference between the thinnest point and apex, same value of less than 0.5 is considered to be safe. Then the Bade display or the Berlin-Ambrosio ectasia display, look for drop in curve. When it is, you have to see for how much the curve is dropping within the 6 mm zone. If it is very significant, again it has to be viewed with caution. The lazy S or the curve where it is shooting up and moving up, we have to view it with caution. So pre-procedure, aim for a residual stromal breadth. Initially when you are starting maybe with around 300, you can drop down even up to 280 or 270, but again that needs some expertise and you have to be totally perfect with reading your corneal topography. Thank you so much. I just want to say one thing: clinical examination and history is definitely has to be included in our workup. Just viewing the topography and then saying a patient is fit for surgery is not the way forward. Thank you.